and kind of jump right in. So first off, if I haven't met, my name is Mike Roby. I'm a family practice trained physician that is our current vice president of physician services here in the South. I take care of all of our docs down here in the South, and have worked with the Health Network in the past as their associate chief medical officer. And I'm acting as the interim medical director for them as we search to fill that role. So if you guys joined us last month, we kind of talked a little bit about HCC coding and value-based care. And then what we've done is I've recruited some other docs to help out over the next 6 months. And we're going to kind of take kind of disease processes and just kind of talk through them a little bit in regards to ways that we can improve population health. So whether it's vaccines, whether it's cancer screening, like we're going to talk about today, diabetes, hypertension, other things like that. So the goal is for us to kind of do a very basic review of what those requirements are. And we're kind of doing it at all levels. So we may have some, medical assistants jumping in. We may have some providers jumping in. We may have some APPs. So we wanted to be able to design these presentations to kind of be all inclusive. So you'll notice as I kind of walk through and we look at our agenda for today, I'm going to kind of just rehash quickly kind of what value-based care looks like, just super quick, nothing like last week when we last month when we dove deep into it. Just a very quick refresher in case anyone kind of missed out. And then we're going to dive into the 4 main cancers that as a value-based system, we put a lot of weight onto. And it doesn't mean that other cancers aren't as important, but it really, if you think about it, it's really the cancers that we have really good screening mechanisms for. We have well-established evidence-based medicine to show how we should screen for these. And because of that, payers hold us accountable to have their patients screened appropriately. And then we're going to kind of conclude today talking a little bit about how do I deal with that difficult patient that doesn't want to be screened? And how do I kind of address those issues? And we'll talk through some strategies and different things in those regards. So if you joined me last month, you kind of saw this, and this just kind of shows us that as we move across the bridge from current fee-for-service to true population health, which you could insert value-based care into there, it really takes a lot of support to hold the bridge up. We talk about, when we talk about cancer care and those types of things, you talk about people-centered healthcare. So, that kind of gets into kind of the motivational interviewing that we'll talk about and how to really connect with those patients. The same with high-value care delivery and advanced primary care. The other thing is that we use informatics and technology to help us close the gap. And we'll talk a little bit about what that looks like. And then really working with our partners. And for instance, one of the things that we have done at Vandalia Health Network is we have worked with Aetna to fund a couple screening mobile units that can help us with our mammography and our lung cancer screening. So, as we kind of walk through, you'll see as we talk today, each one of these boxes, we're going to kind of hit something. And it's because that's truly the foundation for us to get from a fee for service to a population health management. And I have to show my favorite graph that just shows how long we've been trying to do this transition. We've been stuck in that kind of revenue transition period for about 20 years now. So maybe someday we'll get to the full value base, but in the meantime, we'll keep working on building up that foundation that is that bridge between fee for service and value base. Kind of one of the words that we use a lot in value-based medicine is when we start talking about gap closures. And just to kind of be clear as we talk about that, just so you understand, what we're looking at is when we talk about a gap closure, typically we're talking about some type of percent completed versus population qualified to screen, okay? And what we use as our source of truth is typically the payer data. So the one thing that we've gotten very good at over the last year or two within Vandalia Health Network is actually digesting that payer data. Because as many of you guys know, particularly if you're a practicing clinician, when you order a mammogram for a patient, that doesn't necessarily mean the patient got the mammogram and she got the screening she needed. It just simply means you ordered the test for her. And it really doesn't close that gap until you get to the point where they have the procedure and it gets billed for, and therefore we have that kind of source of truth in regards to how we close our gaps. So just to give you an idea from a practical standpoint, what does that look like? What does that mean? So this is data pulled from the Vandalia Health Network in regards to the 4 cancers that we're going to talk about today: lung cancer, colorectal, cervical, and breast cancer. So you can see within that first column, we have kind of our denominator. So those are patients that qualify for those screenings. Now, you notice that the lung cancer screening is a much lower number. And you think to yourself, well, why would lung cancer, like the people that qualify for lung cancer, it doesn't make sense that it would be this few of a number. Well, one of the tricky things is when you look at colorectal, cervical, and breast cancer, a lot of that definition of whether they need screening is really defined by age. Okay. I mean, there's other things that adjust frequency or different things, but it's really an age kind of thing, right? Where with lung cancer, which we'll talk about, you add in that pack per year smoking history. A lot of times what happens is we don't capture all those patients within our EMR efficiently. So therefore, when we look at our denominator, it's actually a little under what it should be. So I think as we continue to work through our EHRs and we work through alignment with Cerner across Vandalia, or whether you have your own EMRs at the FQHCs and different places like that, I think it's going to be important for us to make sure that we're capturing the risk factors that attribute to a patient needing screen for a certain type of cancer. Okay. So when you look at these numbers, they don't look great, but they're kind of not too far off from, unfortunately, what national averages are for a lot of these cancer screenings in at different levels. Now, in West Virginia, we do have a much lower percentage of cancer screening. A lot of that has to do with health literacy and our work. It has to do with access, right? Because, you know, does a patient from Welch have to travel like all the way to Logan or to Charleston to get a mammogram? And how do they do that transportation? How do they get there? And those types of things. And that's one of the exciting things about using these mobile units is we can take a low dose CT scan down to Welch, or we can take a mammography unit down to Welch and really make an impact. And we've seen that some from the WVU health system with their Bonnie bus and their, they have some clever name for their CT scanner too, but Lucas. So the Bonnie bus and Lucas, but they're not able to even come close to meeting the number of patients that need to be screened. So even if you just look at the data that we have within our Vandalia Health Network, you know, we have 30,000 female patients that need a mammography. I don't know of any mammograms that have access to run 30,000 people extra, you know, through. So I think these are areas where we need to kind of be kind of creative and think outside the box as we look for things that we can do for our screening. So like I talked about in the agenda, what we're going to do is we're going to talk through each of these 4 cancers. You know, I think 3 of them have very straightforward screening criteria. One of them is a little outdated from the United States Preventive Task Force, and I've shared the American Cancer Society as well, and we'll dig into that one separately. So colon cancer, I think most people on this call probably know where the colon is and know that colon cancer occurs within the colon. When you look at risk factors for colon cancer, obesity, sedentary lifestyle, low vitamin D levels, diet high in red meats, smoking, alcohol, and family history. And I think as I think about our population in West Virginia, you know, I know when I was full-time clinical, I don't know if I ever got a normal vitamin D level on somebody because of just the area that we live in, sedentary lifestyle, high red meat, smoking. It basically checks the box on most of these. Now, you know, with most of these cancers, I'm going to share some symptoms with you as well, but it's important to realize that by the time patients start having symptoms, it's unfortunately usually in a more advanced state. And the goal with screening is to find these cancers at a super early period in its evolution so that we can affect it with treatment. But when you look at colon cancers, a lot of times change in bowel habits, such as more frequent diarrhea or constipation. I remember, in med school, we'd always talk about pencil thin stool and stuff like that. You obviously have rectal bleeding or blood in the stool, ongoing discomfort in the belly area, such as cramps, gas, pain. And again, if you think about it, by the time that all these things happen, it's usually pretty advanced as far as the colon cancer goes. A feeling that the bowel doesn't empty all the way during a bowel movement because it's partially obstructed. You get weakness and tiredness, usually secondary to the anemia. And patients start losing weight without trying, which is similar with a lot of cancers, right? So the goal is to screen patients early so that we find small polyps, we find small precancerous lesions, and different things that can be taken care of and treated in a much less advanced manner. So the goal is not to have these symptoms, but to do screening. So unless otherwise stated, all of the screening that I'm showing you today is from the United States Preventative Task Force. And that is because that's what our payers use in most cases as kind of their gold standard of what needs to be done. So and the other thing, if you're not familiar with typical like United States Task Force recommendations or just clinical recommendations in general, you kind of like an A is like super strong, and a B is like fairly strong, and then a C is kind of like you shouldn't probably do it kind of thing. Okay. So if you look at A's, so everyone 50 to 75, the United States Preventive Task Force recommends screening for colon cancer, all ages. But then it also recommends screening for colon cancer in adults aged 45 to 49, particularly those that have risk factors. But really, at this point, it's really everybody needs screened starting at age 45. What they do recommend that clinicians selectively offer screening for colorectal cancer in adults aged 76 to 85, but evidence indicates that the net benefit of screening all persons in this age group is really small. So who would you screen within this group are people that have had precancerous lesions earlier on, like maybe at age 70 or something, and you're repeating it. But a lot of it also has to do with the health of the patient. Once you start getting up to like age 85, you start looking at life expectancy compared to what the outcome would be if they had a cancer. So, the big thing to focus on is that 45 to 75 age group. Now, for a lot of our other cancers, screening is super simple because there's one thing to do. For most of our breast cancers, you do a mammography, you do a mammogram. Now, there are MRIs and other things if people are at higher risk, but for the general population, you do a mammogram. For cervical cancer, you do a pap smear. For lung cancer, you do a low-dose CT scan. They didn't want to make colon cancer that simple. So we have some options, but with those options come different time frames of repeating the scan. So we have the old-fashioned FIT test, which can be done every year. Now, if it's a DNA/FIT test, which is like your Cologuard, that can be done every 1 to 3 years. You can do a CT colonography, and that's still, kind of the downsides, and I don't see this as very popular. Some of the downsides are that, one, you still have to do the full prep. And two, if they do see something on the CT scan, they're going to have to go back up in there and take a look at it closer anyways. But that requires every 5 years. You don't see a ton of flex SIGs a whole lot. But, typically if you're going to prep for the colonoscopy and they're going in to do the colonoscopy, they're likely going to do the full colonoscopy. I think back 15, 20 years ago, we saw the flex SIGs a little bit more common because they would be done sometimes in an office setting with a little bit less of a sedation and those types of things. But if you do have somebody that you do a flex sigmoidoscopy on, it is every 5 years. But of course, for you guys that are familiar with anatomy, this really only gets a third of the colon. So it doesn't find any cancers that would be in the cecum area or anywhere like that. And though, however, you could combine the flex sig with the DNA fit or the fit test every year, and that would be suffice. But again, doesn't make a whole lot of sense. And really, the gold standard is the colonoscopy screening every 10 years. So you kind of see that as kind of the gold standard. You can do a colonoscopy, you'll be good for 10 years. And probably the second most common screening tool that's gained in popularity now is the Cologuard, which is the sDNA fit, which can be done every 1 to 3 years. Okay. Does that make sense? Any big questions about colon cancer? And if you recall, let's pop. I didn't realize it'd be so slow. If you recall, looking at our percentages, we're only about a third of the patients that we need to get in. If you look at that, our denominator is 150. So that is about 100,000 patients within our Vandalia Health Network need to have, excuse me, need to have some type of colon cancer screening. So we've got a little bit of work to do in those regards. You know, the other thing, as you're thinking about which type of screening, a lot of things that we come into nowadays has to do a lot with access as well. Okay. Even in areas where we have large amounts of GI docs, we have very large waits to get in for colonoscopies and those types of procedures. So a lot of times if, you know, the access is out, you know, months to a year, then sometimes doing the DNA fit is an acceptable alternative. The second of our 4 cancers that we want to talk about today is breast cancer. So what are the risk factors for breast cancer? A couple of these kind of make sense, right? As you get older, you're more likely to have breast cancer. If we think about patients that we know have had breast cancer, of course, there are some that develop breast cancer at early ages, but for the majority, they're older in life. Those that do typically develop breast cancer earlier on have some type of genetic mutation, whether BRCA1 or BRCA2. And those people are also at higher risk for ovarian cancer. Reproductive history. So if you I always think of it as like a longer period of hormones, right? So if you kind of start your menstrual period before 12, if you're menopause after 55, you kind of increase your risk. So the more estrogen that your breast is kind of saturated with over your lifetime, the more likely you are for breast cancers, because a good number of breast cancers feed off of estrogen, right? So when you start looking at earlier menstruation versus longer delay to menopause, that increases the exposure to high doses of estrogen. People that have dense breasts, you know, so if you have dense breasts, you have a lot more connective and fatty tissues, which can lead to, you know, cell malformations and different things like that. But the second thing is it also is sometimes more difficult to do mammograms on patients that have very dense breasts. So therefore, you may not pick up on a smaller lesion early on. Of course, with a lot of cancers, a personal history of that cancer. So people that have had cancer are more likely to get breast cancer again, and then also people with family history. And then a couple things that are probably a little less common. DES, it was a medication that was used back in the 60s and 70s for like preterm labor. So we're kind of starting to get out of those patients, but there's still a handful of those patients that received DES back in the 60s and 70s that definitely increased their risk for breast cancer. And then anyone that's had radiation treatment to the chest. So not necessarily radiation because of breast cancer, but maybe they had a lymphoma or they had some type of other type of lung cancer or something like that before the age of 30, they have a higher risk for breast cancer. And of course, if you just kind of think through that, you know, anytime you do radiation to an area, it kills cells and cells have to rapidly regrow. And anytime in our bodies that we rapidly regrow something like a cell or something, there's always an opportunity that something's going to get screwed up as it's making that cell and turn into a cancer cell. So same kind of thing when we're talking about radiation. Now, again, with colon cancer, we don't really want to see symptoms because it means we've waited way too long to screen the patient, and that most likely when they do have symptoms, the cancer is become quite advanced. So in this case with breast cancer, we have a new lump either in the breast or in the armpit. If you've had anybody that has suffered from breast cancer, you know that that cancer tends to spread directly to the lymphatics through under the arm. Thickening or swelling of part of the breast, irritation or dimpling of the breast skin, redness or flaky skin in the nipple area or the breast area, pulling in of the nipple or pain in the nipple area, nipple discharge other than breast milk, including blood, any change in the size or the shape, and any pain in the area of the breast. So these can all be symptoms of breast cancer. And again, unfortunately, by the time you start having size formation or size changes, or you start having skin changes, it's really, unfortunately, a more advanced case, and treatment's going to be much more harsh. So again, the goal is to screen so that we can figure out these patients. So the reason I talked about, using United States Preventive Task Force, the problem in breast cancer is that we've been waiting now for over a year and a half for the new recommendations to be released. These recommendations are actually based on 2016 data. So that's almost 8 years old. I think probably during COVID, it kind of delayed kind of the groups meeting, the groups talking about this stuff as everybody was focused on COVID. But, we're hoping that at some point newer recommendations will come out from the United States Preventive Task Force. And I'm going to share with you the American Cancer Society, which you'll see a little bit of a difference with. So again, at this point, with 2016 guidelines, the United States Preventive Task Force recommends every other year mammography for 50 to 74. And then really says that from 40 to 49, it really needs to be a decision making that, women that are at average risk most benefit from mammography starting at age 50. But it just kind of wavers a little bit with what your recommendations are. Now, as I said, most payers look at the United States Preventive Task Force, but we've noticed with most of our payers, because of the delay in new recommendations coming out from the United States Preventive Task Force, that a lot of people actually use the American Cancer Society's recommendations. So this basically says that starting at the age of 40, we should start screening women every year. 45 to 54, they should get one every year. Now, once you hit 55, if you haven't had abnormals, you can kind of maybe stretch that out a little bit. But, we should continue screening to the woman's in good health and expected to live at least 10 more years. And it talks about that all women should understand what to expect when getting a mammogram for breast cancer screening, what the test can and cannot do. So I think, again, that's just the recommendations from the American Cancer Society. So basically it's 40 until you have less than 10 years to live. And they actually recommend yearly. Okay. So this is the one area where we do kind of have two different recommendations as far as who should get screened. But luckily in this one, to simplify, we basically have a mammogram. Now, I didn't put any slides in here or talk a whole lot about, but the one thing to realize with your patients is that there's a lot of development and a lot of work being done in the genetic testing, particularly with breast cancer. I mentioned BRCA1 and BRCA2 as gene mutations that can lead to increased risk. So what a lot of the American College of Thoracic Surgeons and the American College of Breast Surgeons and other people that certify breast centers are really pushing for strong family history screening, and then in those patients that have an elevated score, actually having genetic testing performed. And depending on if you have a mutation or some type of genetic risk for breast cancer, it may change this recommendation. It may ask that you receive breast MRIs, or it may request that you receive mammograms on a more frequent basis. And in some cases, particularly with severe cases of genetic mutations, some women decide to have prophylactic mastectomies to prevent any breast cancers in the future. So again, I would lean on the American Cancer Society. I think most of our payers are paying for mammograms every year now. They've adopted this policy. And I think this is probably the one that has the strongest evidence-based medicine for it. we're just waiting on the United States Preventive Task Force to kind of update their guidelines. The next cancer that we wanted to talk about was lung cancer. So now we've talked about 3 of these cancers. Exposure to tobacco, exposure to secondhand smoke, exposure to radon, and exposure to asbestos. So it's really, this is a disease of exposure. And again, if you kind of think through in kind of a simplified way that cancer is typically formed when something damages the cells and they have to regrow and they have to change rapidly or different things like that. It's the same thing with exposure of all this smoke into your lungs. Because of all the irritation and the tobaccos and the different things, it causes the cells to kind of mutate and grow, and that mutation or growth typically will lead to cancer. Unfortunately, as you saw, we don't find a lot of our patients and screen them appropriately for lung cancer. This is the newest of the recommendations of the other 3. But still, this recommendation has been out for, well, probably 5 to 10 years now. So it's something that we just need to get better at recognizing our patients. When they do have symptoms, again, it usually means an advanced disease that has created issues within the lung. A cough that does not go away, coughing up blood or rust-colored sputum, chest pain, hoarseness, loss of appetite, unexplained weight loss, shortness of breath, and feeling tired or weak. And unfortunately, these could all also be symptoms of COPD or, other types of lung diseases. So, a lot of times if someone is a heavy smoker, they may just kick it up and say, well, it's because I smoked and, move on. But, I think really focusing on these patients. And when we look at which patients to screen, it's really that 20 pack per year smoking. And I'll show you a cool little graphic if you're not sure how to calculate packs per year. But anyone from 50 to 80, so over the age of 50 that has a 20 pack per year smoking history, it's recommended that they get low dose CT scans. So how do you calculate someone's pack a year calculation? You basically take the number of packs that they smoke in a day. So say you have someone smoking 5 packs per day, and they've done that for the last 10 years, then that would be a 50 pack year history. Say that they smoked half a pack a day for the last 40 years, that would be a 20-year smoking history. So you always kind of want to document that, make sure that that's in your record, and that you're able to capture that when you get your prior authorizations for your low dose lung cancer screenings. So it sounds complicated. It's pretty straightforward, just packs per year times years that they smoked it. Now, if you've got a really great historian, which I don't know if I've ever in primary care found a great historian, but they may say, well, from 1980 to 1989, I smoked 2 packs. And then I smoked after that, I did have, but really, as long as you get over the 20, that's all you really need to document in those regards. Now, I put this last, and I thought about kind of rearranging because I always feel like cervical cancer screening is kind of the forgotten cancer screening. When we look at some of our numbers within the health network, it always tends to be one of the lowest ones that we've been able to kind of get people to screen. And, I don't know if it's from an educational standpoint or if it's from a patient's understanding of the risk or that type of thing. Out of the 4 cancers, the other thing to remember is this is the only cancer that has a vaccine that can help prevent it. And we'll talk just a second about that when we look at risk factors. So speaking of that, as we talk about risk factors, you have HPV, which is a virus, a herpes type of virus. And there are certain subsets of HPV that are more prone to create cervical cancer. But that's a huge risk factor. And what we have available to us today is a vaccine that prevents that virus from infecting individuals and therefore reducing their risk for cervical cancer. Again, as you kind of think about HPV and the virus, it affects the cervix, again, changes the cells. Cells have to rapidly regrow. And when cells have to do that, sometimes they mess up in their growing process and they create cancers. Other risk factors that we have are sexual activity, smoking, decreased immune system. STDs like chlamydia or other things like that do slightly increase your risk. 3 or more full-time pregnancies. So if you've had 3 births, that does increase your risk. Long-term contraception use. There's that DES again, that medication that was used for preterm labor. And then economic status. And as I was looking at these risk factors, I kind of stopped for a second on the economic status and kind of looked into that a little bit more. And if you think about it, it's all about access and health literacy. So as you look at things that increase people's risk for cervical cancer, a large number of that is due to lack of health literacy and lack of access to the appropriate screening. I think a lot of our FQHCs are doing an amazing job of connecting to these women and getting them open to come in and get screened and those types of things. Again, if you're starting to have symptoms from cervical cancer, it's very far along in most cases. You'll start having abnormal vaginal bleeding. You'll have unusual discharge from the vagina, as well as pain in the pelvic region, as well as pain during sex. And again, the goal is to find this early, right? So find some small changes to the cells in the cervix, and then being able to kind of either burn or scrape those areas off, and then monitoring is really the ideal treatment for cervical cancer. So from a screening perspective, again, looking at the United States Preventive Task Force, this has changed somewhat in the last 5 to 6 years. It used to be that we started screening at the onset of sexual activity, but that recommendation changed several years ago. So now, what do? So we recommend starting at the age of 21 and going to the age of 65. Recommend cervical cancer every 3 years. If you do cervical cytology alone in women aged 21 to 29, then you can kind of do a little bit different with the age group of 30 to 65 every 3 years with cervical cytology alone, or every 5 years if you get the high-risk HPV testing. So remember I talked about when I first mentioned HPV, there are certain strains of HPV that are more likely to cause cervical cancer than others. So when you think about viruses and strains, you can kind of think about the different COVIDs we had. So we had like the Omega and the Alpha and all those different things. They all had kind of different symptoms and different contagion. Some were more contagious than others and things like that. So this is kind of the same thing when we talk about HPV. There's a set of number of serotypes of the HPV that are more likely to cause cervical cancer. So if you're able to test for those and you find that they don't have any of those, then after the age of 30, you could theoretically push that out to every 5 years. Women that have had a hysterectomy, if they had a hysterectomy for non-cancerous lesions, so they had their cervix removed because of fibroids or something, then they don't need a pap smear because there's no cervix to do a pap smear on. However, if part of that surgery was because they had a CIN or they had a history of dysplasia, you still want to do a pap smear of the cuff of the vagina, because there's always a possibility that cells were retained and kind of could still, part of the cervix could still be there. So you want to make sure that in those patients you do. But in those that have had hysterectomy for non-cervical cancer reasons, you don't need to do a hysterectomy. It's not recommended to do screenings before the age of 21. Now, that doesn't mean that if a patient's not having symptoms or there's other reasons to do a pelvic exam, but this is just clearly for the fact of purely screening patients. And then we can stop screening at the age of 65. If they've had adequate screening up to 65, they haven't HPV and all that stuff's good, then at 65 we can stop screening. So we've kind of reviewed those 4 cancers. We talked a little bit about signs, symptoms, how all that works. But what about, how do we get patients to screen? So it's time to to turn our focus on some techniques and abilities for us to be able to get our patients to do these screenings. So, as I was kind of putting this together, I started thinking, and I don't know how old, if you guys have kids or different things, but it's not necessarily just a kid thing, but my kids grew up in a school system where they looked at habits of the 7 habits of highly effective people. And there's kind of like a child curriculum to it. And I remember, habit 5 in that book by Stephen Covey is seek first to understand, then to be understood. And I think the very first thing that we have to do with our patients is we have to understand what the barriers are that are preventing them from going and getting these tests. Now, some of those barriers are social economic barriers. One, they can't get transportation. They're worried about the cost of these screenings, other things like that. But then some of the barriers are kind of ideas that they have that may or may not be very true. So here's just kind of a quick list of what some of those barriers may look like. So, I'm not at risk for cancer. People like me don't get that kind of cancer. Cancer screening is too invasive. Screening for cancer, that doesn't really work. If I'm going to get cancer, some people feel like screening isn't safe. Again, screening too expensive, takes too much time. If I have cancer, I just don't even want to know I have cancer. I'll just put it off. And I think we've all heard that from some of our Appalachia patients, right? I don't know how to get cancer screening. Health literacy is an issue. I don't have access to screening. I can't drive to Charleston. I can't drive to Morgantown, from an hour and a half away. I don't understand the recommendations. I don't know if I need screens. And then, cancer treatment doesn't work anyway, so why bother, right? Because they have this perception that once grandma got cancer, she died 3 months later. Once Uncle Jim got cancer, he died a month later. So they have this perception because of what they've seen in their life experiences that people just don't survive from cancer. So why even know? I'd rather just wait. So when we think about that, I always imagine this as being kind of barriers, right, or closed doors. And one way for us to think about starting to open that door of cancer screening is with open-ended questions. Because just like Stephen Covey said, I want to understand you so then I can be understood. So if I were to take a look at this list of barriers and I just assume myself that every single patient has every one of these barriers, I will spend 20 minutes trying to address each one of these barriers. But if I move to kind of the stance of, I'm going to slide the door open here. Hey, what do you think about cancer screening? And immediately by giving them this open-ended question, you're starting to open that door and you're going to start figuring out, well, I just don't feel like cancer screenings work. Well, why do you feel that way? Can you tell me more? So you're giving them these open-ended questions. How might we work together to fit screening into your care? And again, once you ask open-ended questions like that, it really opens the door to be able to help them make a decision to decide to have cancer screenings. Now, back in the mid like 2015, around that time frame, there was a very large multi-center trial that used motivational interviewing for cancer screening. So there's kind of these 4 foundational values to motivational interviewing: acceptance, compassion, collaboration, and curiosity. And there's a very simple process of walking through this with the patient. And the success rate with motivational interviewing for cancer screening is definitely supported with evidence-based medicine. So what does this look like on a practical level? What does it look like for motivational interviewing when I'm talking to my patient that has 3 or 4 of those barriers, right? Well, the first thing is similar to the Stephen Covey, you want to engage with the patient. The provider listens to the patient in order to develop a therapeutic relationship and reflect together. Sometimes we talk about empathy, right? So, they may talk about, well, I don't want to get cancer screening because even if you get cancer, you're just going to die anyways. And you can kind of empathize with that and say, yeah, I had an aunt that got diagnosed with cancer and she ended up dying very quickly. But I also have a cousin that, is 20 years post cervical cancer now, or whatever cancer. So really trying to listen, and understand what those barriers are for your patient and start engaging with them so that you start building that therapeutic relationship. For those that are in primary care, you understand that therapeutic relationship. It's something that you develop with your patients that every other doctor in the community may tell them to do something, but because you have that therapeutic relationship with them, they're going to listen to you. So they may go follow up with the ER doc or a surgeon or something. He may tell, but they're not going to follow through until they come back and talk to their primary care doc, because you have that therapeutic relationship. So it's engaging with them and developing that relationship. Then you want to help them focus, right? So you want to provide, the provider seeks clarity of the goal and start a conversation about behavior changes. So maybe your goal is to get one of those 4 screenings done this year. And you may think through yourself, this is the one that they're highest risk for. I got to try to nail this one down today. Because I think if you don't stay focused and you just say, hey, welcome to your annual wellness visit, we have to screen you for 5 cancers today. Here's what we're going to do. It's just overwhelming. So I think focusing, developing clarity of a goal, and starting a conversation around that is very important. The third phase of motivational interviewing is the provider works to understand and augment the patient's motivation for change. You're evoking that change. So maybe you can find something like grandchildren or some other type of motivation that's going to get them to want to make that change. Once they have that relationship with you, they start focusing and seeing what that goal is. What is it in their lives that you can motivate them with to get that done? A lot of times we can engage children, grandchildren into the fact of, hey, I understand you just had, a brand new grandchild or a great grandchild. Don't we want to be around to see a lot of the milestones, a lot of the life check boxes for them? What better way to do that than to make sure we don't have some early cancers, that we're there for them, we're able to be with them. And then comes the planning phase. And the thing to remember is that motivational interviewing, the success of motivational interviewing is not whether or not the behavior is changed at the end of the appointment. Okay. So don't necessarily feel defeated if at the end of that annual wellness visit, you didn't get them to agree to do any cancer screening. But the patient will start thinking about, I often tell medical students, right, it's kind of like planting the seed, right? We plant the seed and then we're going to water it over the next couple visits. And we do that with a lot of diseases, right? Maybe with diabetic management or other things. We know really where the patient needs to be, what they need to be doing, but it's a matter of getting them to that phase of them making that decision to participate in their health. So, don't always feel defeated at the fact that after you have your visit with them, they're not going to get their mammogram or they're not going to do color guard or get their colonoscopy. But just remember that energy and focus that you're putting into the patient, you may not see the results right away. So it may not be immediate, but it hopefully will eventually come. And then, just to kind of come to a conclusion here, just remember, cancer screening can save lives. So even if you're a provider, you're a medical assistant, you're a nurse that helps with a lot of this population health stuff, you can really make a direct impact into those patients. So with that being said, I'd love to open it up for any questions or comments, things that you guys are doing that you're killing it when it comes to cancer screening. Or if everybody's still eating. All right. They're so quiet, Michelle.
I know, and I got to tell you, this was one of my favorite topics when it was picked because I think it ties into so many of those initiatives that get attacked during the well visit, and I love the spiel you gave related to that motivational interviewing because it's so important from an engagement factor.
It does look like Dr. Lohace has a question. Nancy?
I'm just piping in because I know you want a question.
I do.
He
I
likes
do. 'Cause
questions,
I don't feel
Nancy.
successful if I don't. So thank you.
The thing that I think is has been hard for me anyway is that the recommendations change really often. Medicare lags behind.
Yep.
United States Preventative Task Force lags behind, and you never really know what the payer is going by. So it makes all things very confusing for us on the at the end user, like you said. But most recently, with the follow-up of colonoscopies when they're abnormal or even slightly abnormal with polyps, and when we should be scheduling those follow-ups. It seems like even some of the consultants don't really have it solidified or standardized. And how do you deal with that?
So you just gave me a wonderful idea. So I think as a health network, there's a couple things that we can do that addresses some of those concerns. I think, and I actually started thinking about this as I was putting this presentation together, but I'm a little bit of a procrastinator, so it didn't get finished till this morning. But I think one thing that we can do as a takeaway is I think it would be very handy for us to put a one-pager together if there are any differences of what payers are paying for as far as the screening. I think they're pretty much all aligned, but even if they are all aligned, I think getting that resource out to you, okay? But I think the bigger thing that you brought up is something. So we're getting ready to push out this low dose CT scanner, right? That will drive around the state and hopefully scan thousands and thousands of people. What do we do with all those results? There aren't enough thoracic surgeons in the States. There's not pulmonologists everywhere. We've got to make sure that our primary care docs understand the most updated guidelines in regards to repeat exams, what size of a lesion requires them to see a thoracic surgeon, what requires them to see a pulmonologist, what can just be watched. Now, a lot of times in the reports, they give, kind of those recommendations, but I think that's something that we could do as a health network to really try to pull some education together. When you talk about from a GI standpoint, I need to work with our, here in Charleston, we have a residency or fellowship program. And I think getting them as maybe one of their fellows to put a little project together of, hey, when you guys find stuff, you guys tell the patient, hey, I'll see you back in 5 years or 10 years. But sometimes that doesn't get back to us as the primary care doc. What am I supposed to do when they have this or the past shows this? And just kind of a little one-page thing that you can just kind of keep on your computer somewhere as a resource. I think stuff like that might be very helpful for us as physicians. And even sometimes the specialists get asked questions about something that's well out of their typical wheelhouse. So those are two really great points, Nancy. Thank you. And I'll work with the team on those. Dr. Byron?
Hey, how are you? It's Brandon Byron
Good.
up in Morgantown. Two things I wanted to kind of bring up. First is just I'm sort of just curious from the group. Cervical cancer screening is the biggest challenge that I have, just mainly because many times they prefer to go to a female for their gynecologic care. I'm just curious about women over 30, if people have experience with self-collection of HPV testing that can be done in office as an alternative that can be done point of care in all primary care offices across the board, and whether or not people have found success with that. And then the second thing, and this is something we had discussed in one of our pop health meetings earlier this month up north, is that I'm wondering if we can get a consensus sort of informational thing about what sort of incentive plans that a lot of the Medicare Advantage plans have. I'm familiar with the Humana plan where, and this has been a bit of a selling point with some of my patients, that look, they'll actually give you gift certificates if you get your mammogram, if you get your colon cancer screenings, if you do wellness things, if you get your Medicare wellness visit. But I'm not really aware of whether or not there's a a lot of other plans that actually do those types of things. But if we have that information to get to people, that it could be another way to break down another barrier.
Absolutely. So first with that, Katie, I saw you kind of pop up on the video. Do we have that already put together?
So we do, of sorts.
Okay.
And I say of sorts because general guidelines, yes, all of our Medicaids offer patient level incentives, as do our Medicare Advantage. The caveat there is the patients have the opportunity for so many different plans with each different payer. It's hard to nail down exactly what that patient has available to them as far as specific incentives. So we can put together, or we have general guidelines as far as incentive plans, but we always advocate for the patient to actually connect directly with their insurance company to make sure that they have all of the details right. Sometimes you have to sign up for a special rewards program, for instance. I know that's the case with Unicare.
All right. So, but let's try to put something, that's our kind of our third takeaway. I think that's something we could try, put together the best we can, and then kind of put a disclaimer on there. Hey, make sure your patient kind of checks. The self-PAPS is a very interesting thing. I actually had this conversation with a gyn-onc doc not too long ago, and she was using it particularly in the low socioeconomic areas, on mobile units and different things like that to help with that screening. Does anybody have any real world experience with the self-PAPS? Okay. Let me try to get some information from my gyn-onc and my OBGYN team, and let's see if we can try to get, I think that's intriguing because I think that would significantly increase compliance with cervical cancer screening. So, and as I mentioned, that's one of our lowest ones historically. So, Nancy, did you have another question, or did you just hit the button?
I just wanted to say that I think your idea of putting together some sort of spreadsheet that tells us exactly what each payer is willing to pay for with screenings is really a good idea. An example of that is the lung cancer screening program. Medicare has cut off the guideline at 77, whereas the United States Preventative Task Force says 80. So, those of us on the ordering end, we send a patient to the hospital, and this is a problem because it used to be caught by ACR. And now that ACR has been removed and revoked by the government, there's no one checking to make sure that we've checked all the boxes when we order a lung cancer screening. So it's even more difficult for us to make sure that when the patient arrives at the hospital or wherever they're having their lung cancer screening, that they meet all criteria for the payer that is paying for the procedure. And that patient, you may have said, you know what, you really need this screening. You've done all the lung cancer shared decision making, and then the patient shows up at the place to have their test done, and they're only there to be told, well, you don't meet criteria. So we want to avoid all that. So agree that this spreadsheet would be really helpful.
Well, we need to put that together too. That's a great idea, and that's one of the challenges is we're planning out what the low dose CT scan is going to look like. Is part of that is making sure we do the correct prior authorizations. Anybody else? Guys, I hope you're finding these helpful. The good news is for the next 4 months, you don't have to listen to me. I've made other people, I've twisted their arms, so they'll be coming on board to give us kind of these brief little talks. Again, I hope you guys gathered something out of it. We try to keep it at a level where anybody in the office can listen in and hopefully get some information from it. So we thank you guys for your participation, and thank you for all you do to take care of your patients every day. Thank you, guys.